Hi everybody, my name's Will Creene. I'm here to talk to you today about radiological technology experiences in the humanitarian sector. So I am a radiographer. I have worked mainly at the IWK since I graduated from Dalhousie School of Health Sciences as a CT tech, an IR tech, and a general radiography tech, as well as at the QE2 and at Copaquid. I am now working as an educator in a term position at the School of Health Sciences. I'm going to talk to you today about my own humanitarian experiences with two organizations, Mercy Ships and the Canadian Red Cross. And I'm just going to start with a definition of the word humanitarian, which is concerned with or seeking to promote human welfare. So we're healthcare providers. As healthcare providers, we're all in the business of doing this, right? We're all in the business of seeking to promote human welfare. So it's quite a broad topic. I'm going to start with my experiences with an organization called Mercy Ships. I'm going to talk a little bit about the mission and model of Mercy Ships, the surgical programs and case studies that I saw when I was there, and I'm going to just talk about my own experiences as a volunteer and as a humanitarian. So, as you might guess, Mercy Ships own and operate hospital ships. They currently own and operate the Africa Mercy, which is the world's largest non-governmental hospital ship, and they also have currently in construction the MV Global Mercy, which is going to more than double the capacity of Mercy Ships to deliver healthcare to the developing world. And specifically the focus of Mercy Ships is surgery. So it's all about delivering safe, free surgery to the developing world and developing the capacity of developing nations to deliver their own safe and affordable and timely surgery. Now, when I first went to the ship, I went to Cameroon, and this around about this dot, I figure, is where my cabin was. So I was staying in a 6-berth cabin, so 6 bunks, and the hospital, pretty much everything behind that is the hospital on this deck of the ship here, the 3rd deck, and there's 7 decks of the ship. So this is pretty much how much ship you need to support 1 deck of hospital. Now, when I say hospital, it's a fully decked out hospital, so the focus is on surgery. So there's 6 operating rooms, there's 72 ward beds, there's an ICU, a lab, a pharmacy, and of course CT and X-ray, which was my business when I was there. It's decked out, state-of-the-art ship with a hospital on board. So it's same standard of care that you would receive in the developing world. It's staffed from people from all over the world. So there's many expert minds from all over the place providing healthcare here. As well as the ship, there is the Hope Center, we refer to it as. It's the shoreside clinic that's basically patients who aren't currently getting their surgery or aren't in an acute enough situation to be on the ship in the hospital, they'll be shoreside on an outpatient type clinic setting that they can stay at. Now, the ship is staffed pretty much entirely by volunteers, so there's over 400 volunteers on board. There was about 415 to 420 when I was there both times, and those volunteers are there to provide world-class surgery and medical training to developing nations. And many of those volunteers are medical professionals, so there's nurses, there's radiographers, there's surgeons and physicians. There's also many jobs on the ship that do not involve the healthcare directly. So as well as the hospital, we need to keep fed, we need to keep the place clean, we need to keep the ship afloat, so there's many seafarers on board and engineers. We need oxygen for the hospital, we need refrigeration, air conditioning, HVAC, everything. So there's many engineers on board. There's basically everything that you need to run a ship and a hospital and a community. So there's 400 people that are living on board. So everything that you need is self-contained on the ship, and volunteers live on the ship, they work on the ship, they eat and sleep on the ship, and obviously you can go to visit shoreside whenever you want, but the hospital and everything is self-contained on the ship here. And the ship normally will stay in one country for about 10 months at a time. So we'll dock in a port and do surgery and deliver for about 10 months at a time. Now, focus is on Africa. And why Africa? We all know that Africa is the least developed continent. This is the United Nations Development Project's Human Development Index. So we know that these countries score low on the development index. And what does that really mean? Well, Cameroon, which is this country outlined here, was where I went the first time that I served with Mercy ships, and Guinea, I had the privilege of going there the second time that I served with Mercy ships. And these are countries where access to healthcare obviously is limited, but access to even basic infrastructure, roads and sanitation, clean water, electricity, they're things that are not an everyday reality for many people to access. So if you don't have reliable access to those basic needs, your chances of seeing a doctor when you get sick are very limited, and your chance of seeing a surgeon and an anesthetist, everyone that's involved in a surgery, are very, very slim for many people. They just do not have access to it. So now, you might ask why surgery. So that's why Africa. There's very limited access to healthcare and to surgery, but why is the focus on surgery? Well, first of all, 5 billion people worldwide lack access to safe, affordable, and timely surgery. So safe, affordable, timely, those are the three kind of major things. There's no point accessing surgery if you can't get it in a time that it's going to make a difference for your health condition. If you can't afford it, you cannot access it in any way, and it has to be safe. So that doesn't just mean safe surgery. It means safe sterile processing, safe anesthesia, safe post-surgical care, post-anesthetic care, and so on. So it's a big picture. But you know, why, when people think about humanitarian organizations, and especially in Africa, they think HIV, tuberculosis, malaria, all those kind of tropical diseases that you think of. And this is the answer to that. Why is Mercy Ships addressing specifically surgery? So there's many organizations that are dealing with malaria and other tropical diseases. The Gates Foundation, for example, amazing organization, doing a lot of work to help prevent malaria, HIV and AIDS, tuberculosis. There's many organizations that you've all heard of that are addressing this slice of the pie. But surgery, if you lump surgical conditions together into this slice right here, conditions that could be treated or prevented with access to safe, affordable, and timely surgery, that becomes a major, major segment of global preventable death that we can address. Because in some of these tropical diseases and stuff, there is a research gap. There is, there's no vaccination against HIV and AIDS, for example. So there is still research to be done here. There's many challenges that any of these areas face, but surgery is an area that we are really, really good at in the developed world. We're good at safe anesthesia, we're good at safe surgery, we're good at sterile processing. We know very, very well what we're doing and how to do it. And so when you lump all of these surgical conditions together, it just becomes, it's solely an access problem. It's not that we don't know how to address this, it's just that we do not have the resources distributed in the right way to address this. So it's just about getting access to people who need it. And that's where the ship comes in. So the ship specifically allows a few things. It allows us to deliver safe surgical care in a safe and secure and self-contained package to the developing world. So the ship has all the infrastructure necessary to provide safe and high-quality surgery. It allows us to deliver that high-quality surgery and post-surgical care on board, and it allows us to host medical expertise from all over the world. The second thing it does is that it provides a base for us to train local healthcare providers in providing safe surgery and delivering healthcare. So that includes surgeons and anesthetists, physicians, nurses in all areas of specialty, and it has a contrast to the kind of in and out model that many organizations follow. So there's organizations like Operation Smile, and great organization. They go to a place and they do a bunch of cleft surgeries and they leave. They have this kind of in and out model where they're doing one very specific thing, and that's great, but it faces a lot of barriers. there's a lot of cost in flying a bunch of people to one place and doing something and then everyone leaving. You need a secure site to do it, a safe site to do it, where you have reliable access to power and clean water and so on. And so it becomes a heck of an organization problem to set up all this infrastructure and do something and then leave. And often, these organizations are integrating themselves into local systems, and that's the best way to do it. But those local systems do have their infrastructure drawbacks and challenges that they face. So the ship is a self-contained package. We know we have reliable power. We have engineers that live on board and are really good at that. We know that we have oxygen, we have refrigeration, we have everything that we need, basically. To deliver a consistent, kind of standardized model of healthcare with experts from all over the world. Now, so if we have this logistical problem of, we know that we can do surgery and we know we can do it safely, but how do we get it there? The ship kind of overcomes that in a way. Obviously, it does come with a drawback, which is that it can't go on land. So fortunately, 75% of people live within 100 miles of a port city. So we can still reach a very large number of people with this. And Mercy Ships makes tremendous efforts to, when they're in a port city, they will go into the country, into various rural areas and get patients, recruit patients with large screening events where they have people come and basically give patients appointments to say, okay, if you can come to the ship at this time, we'll be able to see you. And so they make a very, very great effort to go inland into the country and find people who have been deprived access to healthcare. As well as that, the ship stays in port for 10 months at a time. So during the period of field service, there's a long time for patients to get to the ship, to hear about the ship, for us to reach out and recruit patients and get the word out there that we can actually help people. And we also have the possibility to follow up for a long time. So patients that have complex orthopedic surgery and they need physiotherapy or occupational therapy afterwards, they need post-op x-rays every couple of weeks to monitor their progression and so on. We're there for a long time. We're there long enough to do all of that. So we don't have that in and out model. We have a more sustainable long-term model. So I'm just going to go through kind of a basic overview of the surgical programs here. So this girl, we have quite a few pictures of patients in this presentation. You might have seen one earlier as well. And just to clear the air on that, so these are all patients who have agreed to be communications patients for Mercy Ships as an organization. So what that means is that they have agreed in an informed consent environment to be included in promotional and educational materials. And obviously at any given time, they have the right to refuse that. But it's done in a zero pressure environment that they have the option to be involved in those materials with us. So just to clear the air on that, I do have some photographs of patients here, and this little girl here is an example of that. She's a communications with Mercy Ships. Her name is Justine. You can look her up if you Google Justine Mercy Ships. You can look her up and find out all about her story. And really, really great patient. Just a bundle of joy. You can see here she's full of character in this picture, and we're going to come back to her in a little bit. I'm going to go through each of these surgical programs and talk a little bit about each of them now. So we're going to start off with maxillofacial. Cleft lip and palate repairs are a big thing, and we're also doing a lot of medical capacity building in cleft lip and palate repairs, and maxillofacial tumors are also a big area of what Mercy Ships is addressing. So this example, this patient, I actually took this scan like on, I think it was day 2 or day 3 of me being on the ship for the first time. So this patient walks into the room and they have tons of dressings on their face. And I kind of did a little bit of a double take and thought, wow, this patient's had some really, really extensive surgery. And you greet them with a smile, and I brought her in and put her on the table, and we did the scan and everything. But I had that initial reaction of like, wow. And when I stepped back to the control booth, my coworker that I was working with was there, and she said, wow, she looks amazing. And to me, I thought, okay, that's like, she's obviously had this crazy surgery. What did she look like before? She looks amazing now. And this was her before scan. So she has this huge ameloblastoma. It's an odontogenic tumor, so it arises from the cells that produce enamel in your teeth, and it's basically completely destroyed her maxilla on the left side. It's occupying the entirety of her maxillary sinus, what would be here, and pushing way back in here into the ethmoid. It's actually pushed this optic globe out of the orbit here. So you can see her eye is pretty much entirely out of the orbit. The optic nerve is stretched right out here. And she actually could still see out of that eye, interestingly, and she did retain function in that eye after her surgery. But yeah, really, really severe, and yeah, amazing case, really. And you can see this tumor is basically the size of this poor girl's head. Now, she came on the ship, she received surgery, and she did quite well. And you can see the eyes back in the orbit here. A lot of this has been reconstructed, and she actually had a metal plate here, and this is a parietal bone graft. So they took bone from the parietal bone here and grafted it on to kind of reconstruct a maxilla, to give her kind of a normal face shape. They've kind of reconstructed the zygomatic arch here and reconstructed some of the orbital rim here, and grafted it on to connect it to the opposing maxilla on the side there. And she still does have some teeth and stuff on that side, so she can still use those. And patients like this, they often are cast out of their communities. So here's another photo of a young girl who's had extensive maxillofacial surgery, and often these patients are basically abandoned by their communities, or in the case of a young patient, the mother and the child will be cast out of the community. And these are rural communities. There's a lot of superstition and kind of folklore that goes back many generations about conditions like this, cleft palate and whatever, that it means that the person is cursed, or it means that they are a witch, or they are being punished in some way, or they're a cannibal. All these kind of crazy, to us, sound like crazy superstitions, but in certain cultures, they are very, very ingrained in the culture, and a very active kind of part of that rural culture. And so these patients, they often are just completely cast out of their communities. They don't experience love and compassion that they get to experience when they come to the ship. So it's really fun and rewarding to be a part of this, and especially with the kids, just letting the kids play and kind of be normal and be loved and experience that that they may not have experienced for a long time. And I actually heard a story from one of the screening nurses who was talking to me, and she said that she kind of brought a patient in, and the patient had quite a severe facial tumor and deformity, and she brought the patient in and kind of touched them on the shoulder and sat them down, and she said that when she touched the patient on the shoulder, they recoiled. And the patient said to the day crew that was there, the translator, said that was the first time that she could ever remember anyone touching her for as long as she'd had this growth on her face. And that's how deep it runs. People are completely ostracized, cast out, and people are afraid of them, that they think they're cursed in some way, or that they're going to catch it or whatever. So pretty heartbreaking stuff, but really, really great to see patients like this who are able to kind of be a kid again and play and whatever. So moving on here, I have another interesting maxillofacial case. This is a vascular case, an AVM, and this lady had this large AVM kind of under her mandible here, submandibular, and it's basically, so it's an arteriovenous malformation, and it's fed by this. This is the common carotid artery in the external here turning into the lingual. So the lingual artery comes down here and is what's feeding this. And you can actually see on the axial here, the left lingual artery is substantially bigger than the right side because it's feeding this big vascular mass. Now, this is something that potentially, if it was intervened with early, it could have been excised very easily or just embolized We do kind of AVM embolizations in interventional radiology, but in this case, it's grown quite large, and it was a bit of a job, for surgical excision, and it was successfully removed. Moving on down the list here to women's health. So vesicovaginal and rectovaginal fistula are endemic to the developed world, particularly areas that don't have access to safe maternal and delivery services. So these are basically birth injuries that happen during protracted labor, where there's no access to healthcare and no way to get help when things go sideways. Now, these women here in this picture are having what we call the dress ceremony. So this is each cohort of women that receive surgery for a vesicovaginal fistula. Each cohort, once they have gone through their recovery and they're fully better, they have this dress ceremony where we buy a bunch of local fabric and get a local seamstress to make a dress for each of the women, and kind of traditional headgear, and get them all dressed up, and they share their stories, they share their testimonies of what happened to them, and some of them really are heartbreaking. Some of them are similar to the stories that I was saying before about they are cast out of their communities and ostracized. If you have a vesicovaginal fistula, often there's kind of continuous leakage and so on. So these women may have been left by their husbands, and some of them say they've been living with it for 8 years or 10 years or 12 years. So really difficult to live with for a long time. And they have this kind of ceremony where they get dressed up and celebrate their health and their healing and their womanhood, and it's a very big part of their identity for many women in the developing world, like gynecological health and having the ability to bear children and be healthy in that respect. So this is kind of a really empowering experience for them, that they've had this surgery and they are healing and they are better. Now, this is an interesting case. This was actually a vesico-uterine fistula. So the bladder here on the sagittal, you can see we filled the bladder retrograde with contrast through a Foley catheter, and you can see that contrast is tracking up into the uterus. So this is like the fundus of the uterus here, anteverted, and then it's tracking up into the uterus and then down through into the vagina. And this was a lady who had access to surgery. She'd had a C-section, and obviously it was not performed to a high standard, and there was an injury to the bladder, and the uterus basically formed this fistula with the bladder. So a surgical complication that they were then unable to remediate. So in this case, they took basically a flap of fat and folded it down here, so there should be this kind of fat plane between the bladder and the uterus here that was destroyed. So they took an OMAP and folded that down to restore that. Moving on, so the general surgery program, a large component is goiter. So goiter is this enlargement of the thyroid. It's endemic in developing nations due to malnutrition and the consumption of unsafe staple foods mainly. So in a lot of the developing world, they eat a food called cassava and very heavily rely on this food called cassava. And it's like a root vegetable, kind of like a sweet potato, and it's very famine resistant. It's a very important staple food that makes up a large majority of calories for many people in famine prone areas. And unfortunately, if it's not cooked properly, especially, it can cause this goiter because it contains levels of cyanide. Cyanide is toxic to the thyroid. It causes hypothyroidism, and then because of that it causes the thyroid to grow and grow and grow to compensate. So it mostly happens in women. And this is a nice kind of before and after we have of this lady. So this is probably very uncomfortable, can be constricting the airway, affecting jugular drainage, and so on. So here she is, a lot of character, a big smile on her face afterwards. And here we have another really significant before and after here. So this lady had been living with this large goiter. And again, there is this kind of element of being cast out of the community sometimes, and superstitions that surround this. So big smile on her face. And this is an example of where this can be really, really dangerous for the patient. So in this lady, the goiter is actually extending down into the thoracic outlet here. So there's only so much space between your sternum, your manubrium here, and your spine. And the goiter here, her thyroid is extending down into that space. And when that happens, it's compressing her airway very severely here and would be affecting the jugular drainage too. You can see these large collateral venous drainage here on the front. And yeah, so this is all abnormal thyroid tissue that's extending down behind the clavicles here, behind the sternum, and the airway here is compressed to just a few millimeters on this side. This is the airway, so this should be a nice round patent airway here, and instead we're seeing this very flattened, compromised airway that would be very difficult to breathe through. And then more general surgery stuff, we have this young fellow with a hernia, and this was a case that I thought it was important to include. Unfortunately, this is a patient that we weren't able to help. So sometimes we will give the patient an appointment, they come to the ship and they're seen by the surgeon, maybe they have a CT scan and it's determined actually, unfortunately, we don't, on the ship, we don't have the capacity to help you. So this patient would need basically a large reconstruction with a large mesh reconstruction of the abdominal wall, and it's just too extensive of a surgery to undertake on the ship, and not something that we were able to do. You can see it's a very complicated hernia here. The liver is herniated out through the abdominal wall here. A lot of the bowel and the mesenteric kind of vasculature is all herniated out through the abdominal wall here. So a very unfortunate case, a very complex case. And in this case, we would give the patient basically a copy of their CT scan and all their medical records that we have for them. And if we had any referral pathways with local services, potentially refer them. But again, often we're the last hope for these patients. And if even we aren't able to help them, it's a very unfortunate circumstance, and that does happen. Moving on to plastics, so burn contractures. So burns are a big problem, especially in the pediatric population in the developing world. There's a big culture of cooking outside on an open fire or cooking in kind of a small indoor fireplace, and it's very common also for children to be unsupervised, kind of semi-supervised large groups of kids in a village or an area of the city, all just playing together indoors, outdoors, coming and going. And the result of that is there's often unsupervised children around fire, and sometimes the children either fall in or a toddler is kind of climbing up and pulls a pot of hot water down. So it's quite common to see these burns and contractures on one side of the body, one arm, and maybe face involvement and neck. And sometimes the contracture will extend to the side as well, like it does in this young guy. And basically, when the tissue heals and scars up, the patient has this kind of defensive position because they didn't have, they haven't healed with their arm outstretched to keep those tissues viable. They've healed with their arm kind of curled away, and the scar tissues cause this contracture here. It kind of tenses up and gets tight, and they can't use the arm. And so I think this guy is another patient who was really, really full of character, very cheeky little fella. And I think this must be the only photo of him that exists of him not with a smile on his face, because he was always running around causing trouble. Real pleasure to have around. And here he is in the physio tent doing his occupational therapy. So after his surgery, the contracture has been released and skin grafted the site, and here he is doing his occupational therapy, trying to regain some function in that arm and that hand. And often, like I said, you kind of see patterns of where these burns happen. Often it's by the same mechanism of injury, and the surgeons that are doing this are very, very creative. It's kind of a unique problem, and it's not something that's extensively researched because of the lack of healthcare in the developing world. So they kind of will take creative approaches of using skin flaps, where they will take a flap from the inside of the arm and graft it to the outside to promote healing there, and then return it when it's healed. The very, very creative and interesting approaches that have been kind of developed in purely this context to deal with these types of problems that are very unique to the developing world. And this is also just a good example of the long-term advantages of us being there. So we're there that we can provide all the post-surgical care and the many months of physio and whatnot that this or occupational therapy that this guy would need. And here he is with a big smile on his face. And if you can name one other kid that you know that would be with their arm in a cast, K-wires in their fingers and all of that, but still out there outside riding a bike around enjoying themselves, it's quite a unique prophecy of these kids who've really had to endure so much in their life. They're incredibly stoic. Post-op day one, they're just on Tylenol and they're full of it. They're happy and they're out here enjoying themselves. So pretty amazing population to work with. Now, this is a case of noma, so a gangrenous infection that has affected the face. Again, another disease of poverty, a disease that arises from poor oral hygiene, poor dental hygiene, and also severe malnutrition often. So patients who are very immunocompromised because they're malnourished, they get this gangrenous infection that can arise anywhere, and in this case in the face, from a dental abscess or whatever, and basically destroys bone, destroys soft tissue, and leaves the patient with some of these severe deformities. And this patient did have successful surgery and did well. Unfortunately, I don't have the post-op images, but I thought this was a good case to include because this particular patient, the day after I took this scan, so this was a scan that I did, and this particular patient actually received my blood in the OR the following day. So the African Mercy's Blood Bank is its volunteer crew. And when you arrive at the ship, if you want to be a donor, you can sign up, you do the screening, you get your type and screen taken, and they basically, if a patient with your blood type is going to the OR that day, they will put a little sticker on your door saying, you have a patient with your blood type that is going to the OR, make sure you're hydrated today, keep your pager on you, whatever. And X-ray is right next to the lab actually on the ship, which is right next to the OR. So when that patient needed blood, they came knocking, they said, hey, well, can you come for 5 minutes and give us your blood? And gave him blood, and then within half an hour, it's in the OR ready to be transfused. So yeah, pretty amazing, really, system, and a good way to overcome the issue of storing blood and so on. And with the 400 strong crew, you pretty much always have what you need. So we're nearly getting back to Justine here. I'm going to talk a little bit about rickets. So rickets is endemic to developing nations. Again, a disease of poverty. It's due to malnutrition. So calcium, phosphate, and vitamin D deficiency, all very big problems in areas with poor food security. And so genivarum, varus deformity, also known as bowed legs. So that's what we were seeing in Justine back there, and that's what we're seeing also in this patient. This patient has a very, very severe deformity to the extent that the legs are bowed and the feet are actually completely inverted. So you can see the fibula is crossing over the tibia here, and you're seeing kind of a half AP, half lateral knee, and you're seeing a basically a PA foot because the feet are turned right around, or a PA ankle. So yeah, there you go, you can see it now. So really, really severe case here. And this is the post-op film. So first of all, these are to the same scale. So the patient has gained about 8 inches or a foot in height just by straightening out the legs. And basically the approach is bilateral tibial osteotomies. And obviously this is going to be a messy approach and a very, very difficult, complex surgery in a case like this. But basically bilateral tibial osteotomies, straighten everything out as best as possible, pin and cast, and then the end result is nice long legs for this patient. And yeah, you can see the healing process here has been very, very protracted, and obviously is a severe case. So very, very difficult there, but the right outcome in the end for this patient. Straight legs, and again, a huge gain in height and in the ability to stand up straight. We have another case here. So juniovarum, or a varus deformity, is bowing of the legs. A valgus deformity is knock knees. They arise from the same thing, basically, rickets. And this is an idiopathic pathology, juniorecurvatum, so also known as back knee. So basically the knee, because there's this ligamentous laxity in the posterior aspect of the knee, the femur basically bends forwards as it's growing. And so what you're looking at here is two lateral knees. The tib fib looks pretty good for a normal lateral knee, right? You've got your fibula head superimposed on the posterior aspect of the tibia here, and kind of flat tibial plateau in profile, but you can see the femoral condyles. They're almost superimposed here. So kudos to the tech that did take these images. It wasn't me, but you know, they've almost done a decent job of getting a lateral knee here, considering the circumstances. There is a bit of grid cutoff, you'll notice, actually. So there's peripheral grid cutoff on both of these. My speculation is that in our X-ray room it's very short. So with the patient by the wall bucky, there wasn't enough room to get any SID to get the images, considering the constraint of the patient and any mobility or immobilization devices they may have needed, and so on. So there's a lot of challenges that we're facing here, adapting to these populations and adapting to the limited equipment that we have on the ship. But anyway, pretty good job of getting these lateral knees, and you can see the femur is just basically bent forwards at almost 90 degrees with this patient. So again, an attempt at an AP here with them standing as upright as possible, and a post-op film. This patient had obviously femoral osteotomies on both sides, and cut, pinned, and straightened out, and again a big gain in height as this patient can now stand upright. And the next image is a similar pathology to this, and a patient who is a communications patient. So more images here, and this fella, his name was Ulrich. You can look him up, and his story obviously is amazing. This was how he used to get around. He had to walk with these sticks, basically, to get anywhere, and it has very, very severe example of that pathology we just saw, juniorecurvatum. And here he is after his first leg operation, big smile again, and here he is after he's had both legs done, and a big smile, and this is when he's getting a dressing change. So this is kind of can be quite a bit of a magical moment for these patients, because in his case, he has never seen his legs straight, or can remember ever a time when his legs were straight. So to see that for the first time and have the dressings off and actually see with your eyes is for sure an amazing experience, and always a bit of a mad moment there for those. For the maxillofacial ones too, the first time they kind of see dressing change and have the mirror, it's quite amazing. And here he is post 3 months of physio, cast removed, big smile on his face. And so now I'm going to move on from this. We're going to cut to mercy ships in a little bit. I'm going to talk about the cross and Red Crescent movement for a bit here. So this is kind of my next dabbling in the humanitarian world, the Canadian Red Cross. And people think of the Red Cross as one monolithic organization. It's, you know, the Red Cross or the International Red Cross, but it's not really an accurate representation. So the Red Cross Red Crescent movement is comprised of 191 different Red Cross and Red Crescent societies across the world. So there's the Canadian Red Cross, the American Red Cross, the Syrian Red Crescent, and so on. And there are many different organizations. They're all guided by the same fundamental principles and kind of have the same shared mission. And that mission in the Canadian Red Cross's mission statement is to improve the lives of vulnerable people by mobilizing the power of humanity in Canada and around the world. So vulnerable people could be somebody down the street here in Halifax who had a tree fall on their house during Hurricane Dorian and maybe they just need a hotel for a few nights, or it could be somebody in the Bahamas who had their house destroyed and their village destroyed by Hurricane Dorian. So it's a broad definition, and they aim to do this by mobilizing the power of humanity. So that just means employing the skills that you all have, the skills that I have as a healthcare provider, as humanitarians, to help people who've been affected by adverse events like Hurricane Dorian or just adverse circumstances. And it's not limited to disasters. It could be something as simple as the Canadian Red Cross running first aid programs, or they have this friendly calls program right now where you basically are connected with anyone who wants a friendly call once a week because they're lonely and they're isolated because of COVID, and they can sign up to receive friendly calls from a Red Cross volunteer, and so on. So it's a very, very broad scope of the organization. It's not just disaster relief, it's not just healthcare, it extends across Canada and as well as internationally, as you know. Now, in the international context, the Canadian Red Cross is one of 7 Red Cross and Red Crescent societies globally who maintain an emergency response unit hospital capacity. So that is what you are looking at here. This is a hospital emergency response unit from the Red Cross. And what that means basically is that on any given day, the Canadian Red Cross could pick up the phone and have the capacity to charter a plane within 48 hours of a disaster happening and set up an emergency field hospital. So set up a hospital like this and be able to deliver surgical care as quick as possible. Now, it could be something relatively simple. It could just be like an oral and IV rehydration hospital with a couple wards and just basically a ton of saline and lactate for rehydration for like a cholera outbreak, for example. Or it could be something like what you're looking at now, which is kind of a full-fledged field hospital with an outpatient department, operating rooms, a place for staff to come stay and live on site, and of course, right in the middle here, an X-ray tent. So my involvement in all of this is that I'm a hospital emergency risk delegate. So that means that whenever I indicate that I have availability and that my employer is flexible, I am on an active roster of professionals who at any time could be called to deploy in the event of an international humanitarian disaster, an earthquake or a hurricane or a refugee crisis, a people movement, and so on. And the Canadian Red Cross is deployed in all of those contexts. They deployed a full-scale field hospital following the Nepal earthquake. In 2019, they deployed in Mozambique following a typhoon. They've been involved in many different international operations. And now I personally have not deployed in this context yet. This is kind of the next humanitarian avenue that I'm going to explore, but I am on the roster, and I did deploy domestically actually with the Canadian Red Cross in kind of a unique deployment to Canadian Forces Base Trenton in Ontario back in February 2020. Now, February of this year, you may have forgotten it with all that's gone on, but back in February, we naively believed that the pandemic was something that we were going to be able to contain. So in February 2020, that was when the Canadian government said to any Canadians that were in the Wuhan region of China, come back to Canada and quarantine for 2 weeks. We're going to get you here. We're going to quarantine you at the Canadian Forces Base, and everyone's going to be happy. And so in that case, what happened, we had a bunch of Canadians come back. They quarantined on the Forces Base, and the Canadian Red Cross was not there in a medical capacity. Anyone who was symptomatic ended up going to hospital, but we were purely there in the capacity of delivering basic needs, so delivering meals and stuff like that. And the Canadian Red Cross basically needed people as quick as possible that were familiar with putting on PPE and being able to deal with people in that context. So that's why they called on some of their international team to deploy in a domestic context. So that's why I was there. I just went there for a week and helped get things running, and then the domestic team took over and kind of run the rest of the show from there. But so yeah, that was kind of me just getting my toes wet, my first little deployment with the Canadian Red Cross. But going forward, I'm hoping that in the next time that there is a need, I will be deployed in this context and be able to work in a field hospital and help set up this field hospital. So here's me. This is the in the training week. Big smile on my face after setting up this rudimentary wall bucky system that I've rigged up here. But yeah, this is the X-ray equipment that they have for their field hospitals. So everything you're looking at here basically can be boxed up. And this is what the X-ray machine looks like when it's boxed up and ready to go. This big box here is like the lid of this, so it goes on top of here. This is a box with like a laptop and a bunch of extension cords and just the basic stuff that I will need for my tent. And then this is what the that table that you saw in the last image folds up into. So that is the entirety of the X-ray system that we need for a field hospital, and it is sitting in a warehouse right now in Ontario. And at any given point in time, the Canadian Red Cross could deploy an emergency response hospital, send all of this gear on a one-way ticket to a new site to set up a field hospital, and then the goal would be that that equipment was then passed off to the local Red Cross Society if they had the capacity to absorb it and keep it running, or to a hospital in the local area if they had the capacity to keep it running, and if they don't have the capacity to keep it running, if it's something that might become a burden to them, then the Canadian Cross will repatriate it. But for the most part, this gear is on a one-way, and as soon as it's gone, the Canadian Red Cross will repurchase everything that they sent so that they can maintain that capacity and be ready for the next deployment and the next deployment. Now, this is something that actually, this mobile X-ray in the disaster situation has been around for a very long time. And some of you who are watching, you may not recognize this woman, but you definitely would recognize her name. This is Marie Curie. And I don't need to tell you that Marie Curie is one of the heroes of our profession. She was the first woman to win a Nobel Prize. She went on to become the only woman to win a Nobel Prize twice. And to date, she's the only person to have won a Nobel Prize in two different scientific fields, physics and chemistry. So as if she wasn't brilliant enough, I'm also pleased to tell you that she was a humanitarian and a Red Crosser. And because she was an expert in the field of radiation sciences, as we all know, when the First World War broke out, she recognized the medical utility of having X-ray in the field. So as well as learning and teaching the art of radiography, even to her daughter, actually, she established this fleet of vehicles, which were kind of nicknamed Petite Curies. And they basically went to the front line, and this was the first kind of mobile X-ray that was ever really used. She put together these X-ray vehicles that could go to the front line and deliver X-ray and radiology services for soldiers who had been injured with shrapnel and bullets and needed them removed, and so on, as well as fractures and whatever else. So Marie Curie, as well as being this pioneering scientist, was also the original Red Cross radiographer. So pretty cool. And you can see this imaging unit on the right here. It's got the Red Cross emblem, and people kind of just associate that with like medical or whatever. But again, the Red Cross is this. It's not an organization, it's a movement. And specifically the Red Cross emblem is named in the Geneva Convention as this is indicative of a neutral and impartial movement that is here purely to provide help. It's very strictly outlawed in international humanitarian law to ever misuse this symbol in any way. So, you know, this indicates this is a peaceful vehicle, a neutral vehicle, no weapons, whatever. And the movement was actually founded by a fella named Henri Dunant in 1884, after he personally witnessed the aftermath of a battle, the Battle of Solferino. And he kind of realized that both sides had very many wounded soldiers. Both sides had suffered tremendous loss, and there was no neutral, impartial kind of humanitarian organization, no healthcare that was impartial to both sides to just come in and look after them. So that's how the Red Cross was formed. It was just this neutral service, kind of born in the aftermath of war, this neutral service that could help people regardless of who they are, regardless of what they've done or been involved in, or where they're coming from, regardless of any of that, completely neutral and just based solely on one thing, and that is need. So if you need help at this time, the Red Cross is there to help you, basically. And that brings us back to Justine here. So big smile on her face, and basically Mercy Ships here, delivering hope and delivering surgical care to people who really need it. And a lot of people in the developing world, they've never had access to healthcare. They've never had a reason to access that anyone, a reason to believe that anyone would provide access or provide help to them. So being able to see patients like this and have them become a part of our own lives is really, really an amazing thing. And this kind of Mercy Ships is motto back to Mercy Ships, hope and healing. So they're not just doing surgery, they're bringing hope and healing to people who previously may have had none. So here is Justine coming up the gangway, and this is an iconic photo because this was the first patient to come on board in Cameroon, and she's been carried up by her day crew member here, and the day crew are kind of translators, patient aides, and so she was carried up the gangway here, and here she is walking down on her own. And at this point, this was after her last trip to the ship, so she had some kind of final x-rays and a few, saw the surgeon the last time and whatever. And you can see she's been to the x-ray department because she's got all of her great patient stickers all over her arm. But so here she is walking down the gangway on her own, and she actually at this point would have walked up and down the gangway on her own many times, because that's one of the exercises that the physiotherapists who have their tent shoreside would often have the patients do. So at low tide, the gangway sinks down, it's on rollers, so it's a lot easier to get up at low tide. So they kind of would start at low tide, and then if it was a difficult physio day, they would be going up at high tide when the stairs are that much steeper. But anyway, the healing that you can see here, it's not just physical, it's really the whole package. You can see even her dad is in the background here, proud father, and he's in this picture here too, kind of smiling on. And so here we have a picture of her in the x-ray department getting some of her many x-rays that she would have had. Here she is dressing change, so again that big smile on her face getting the dressing change, and as I said, she is full of character. And here she is with a big smile on her face in the physio tent, presumably having just done the balancing beam here with her arms out. And yeah, it's the kind of parting message here is that as healthcare providers, we are humanitarians. We have the opportunity to be involved in this, and it's pretty magical. It's really, really, we have the power to put a smile on someone else's face at the end of the day, and it doesn't have to be glamorous. It doesn't have to be anything. It can just be something as simple as putting a smile on your patient's face after doing their x-ray or after doing their exam, something that maybe they were quite nervous about. And there's not many jobs where you have the ability to make someone's day and make something that is stressful easier for someone else. Make something that that someone kind of dreaded or that was a negative area of their life, and still manage to put a smile on their face about it. So it's very, very easy, in Canada to get into this day in, day out, where you're dealing with whatever on the day, and it kind of you lose your compassion, and you lose that reward of what's in it for you as a provider. And for me, I definitely got a huge amount from this experience working in this context. I feel very grateful and indebted to my patients that the amount that I was able to get from them. And so if there's one thing that you take from this, basically it's, we as healthcare providers have the ability to put this smile on somebody else's face. So show up with a smile to work and try to do that. And if you've done that with your day, then it was a good day. Thank you for listening. If anybody has any questions or anything, be a somewhere for people to email me, will.creene@dal.ca. If you have any questions, I'm more than happy to be in touch and to hear from you. Thanks.